The kingdom is here, the kingdom is now. The sent ones go to the nations. It has been written, declared in your will. Now the kingdom must be revealed. In these last days, your spirit poured out. It's time to reap the harvest. As we carry your spirit, let glory rise. We will not be defeated. Freely you gave, so freely we give. We will establish the kingdom. You be revealed.
Welcome to the Advancing the Kingdom podcast. We're streaming live on all social media platforms and podcast streaming channels. Get ready for a revelatory teaching from our apostle, Matthew Tillery.
Well, greetings. Thank you so much for tuning in to the Advancing the Kingdom podcast. I am your host, Matt Tillery. Listen, we really appreciate you today. Thank you so much for taking time to listen and watch the podcast on tonight. Tonight is going to be a great night. Of course, it's fourth Monday night, and on fourth Monday nights, it's my guest, Keeping It Real with Dr. Gooch, Dr. Denise Gooch. She's here in living color tonight, and we really appreciate her taking time to come on the podcast tonight. Thank you so much, Dr. Gooch, for coming on again tonight. Appreciate you.
Thank you. I'm actually looking forward to our podcast tonight. Thank you for having me.
It's going to be a great conversation tonight, and we're going to go ahead and jump right into this conversation tonight. Just really, somebody asked the question, Matt, why are you always talking about prostate cancer? And my response was, listen, when African-American men stop dying from prostate cancer, then I'll stop having that conversation. But until then, I think it's a needed conversation. I think the faith-based communities need to be involved in having these types of conversations, because a lot of black men are dying that and we talked about it, that they shouldn't be dying with prostate cancer.
Yes, African American men are 2.5 times more likely to die from prostate cancer than men of other races. And as we've talked about, prostate cancer is the number one diagnosed cancer in men, number one. And unfortunately, it is the number 2 cause of death for men from cancer, number 2. And then you have African American men that, if you look at the statistics, 1 in every 8 men will be diagnosed, well, 1 of every 9, 1 of every 8, depending on what statistics you look at, will be diagnosed with prostate cancer, but 1 out of every 6 African American men will be diagnosed with prostate cancer. So that's why you bringing up this subject and giving this information is so important, because I've said on some of my other podcasts is that African American men are more likely to be diagnosed with prostate cancer than women diagnosed with breast cancer. But no one says that. You don't hear that information. Right.
Wow. So why are African American men at higher risk for prostate cancer compared to other groups?
That's a good question. Really, I don't know if we really have a clear answer to that.
Wow.
But it isn't just African American men. Men of African descent have the highest incidence of prostate cancer. So both in this country, as well as African men, as well as Caribbean men. Wow. So men of African descent have the highest risk of prostate cancer in the world.
Wow.
So this isn't just something local, regional that's going on in the U.S.
Wow.
And that's data that we know.
Right. And we talked about this last month as well. Why do so many of us avoid screening? And do you think we can change that mindset?
Now that's $1 million question. But I will tell you why men do not want to be screened for prostate cancer. And I actually mentioned this on another talk program that I was on, because, and men have told me this, and I do understand this, because the prostate is part of a man's genital urinary system, which is basically, his male reproductive system. So men are concerned about the risk of erectile dysfunction. if they are diagnosed with and or treated for prostate cancer. And the truth of the matter is their concern is real. The
Right.
prostate is part of a man's genital urinary system as well as his reproductive system. So there are risks associated with being treated for prostate cancer. We can talk about some of those risks, and depending on the treatments, some treatments do carry a higher risk of having both impotence or erectile dysfunction or inability to get an erection, as well as incontinence, which means that inability to hold the urine. Unfortunately, it is seen more often when men have surgery. Now, no shade on my urology colleagues,
Right.
but I don't think they emphasize to men the risk factor and how high the risk is when they have surgery for prostate cancer and their risk of erectile dysfunction as well as incontinence. And really, if you look at the data, even for a man who has what they call nerve sparing radical prostatectomy, 30 to 40%, that may be conservative, of men will still have erectile dysfunction after the surgery. And if a man has non-nerve sparing, which means they just kind of, cord out the area and to get the prostate cancer out,
Right.
50 to 60% of men who have that surgery are going to have erectile dysfunction or be impotent. And go ahead, sir.
No. I was going to ask: is that something you have to request before surgery? That in terms of sparing the nerves, or is that what the surgeon determines that needs to happen?
Well, that's a good question. Doing from my research, of course, I'm not the surgeon,
Right.
but the surgeons can actually, I think, on the consent form, say they are planning to do nerve sparing. This is what I've been notified, and this is what my research has shown. However, if they find that maybe the prostate cancer is more locally advanced, more closely associated with maybe the urethra, the sphincter that's actually draining the urethra, that's, the prostate, the urethra goes through the prostate. And if they're not able to get around those nerves around there, then they're more likely to damage it. And so they can't make that promise. They're going to try to do nerve sparing.
Right.
But depending on what they need to do the surgery, then they may damage some of those nerves in the process.
Wow. So are there any early signs of prostate cancer that men should look for?
Well, unfortunately, there are no real, I guess, distinctive early signs that men can say, well, I have this symptom, because most men, once as a man ages, the prostate is right there at the base of the bladder. And as I just mentioned, the urethra passes through it. So as a man ages, his prostate actually kind of, what they say, hypertrophies or gets larger as a man ages, which unfortunately kind of squeezes his urethra and makes it harder for him to urinate. So a man is more likely to have urinary urgency and frequency, maybe an inability to hold his urine, having to go more frequently. That doesn't mean it's prostate cancer, but that is a common symptom that men have that may send them to the doctor to have a workup and to try to find out what's going on and maybe get some testing. But a man can have, that's oftentimes called BPH, benign prostatic hypertrophy. Hypertrophy just means enlargement of the prostate. So a man can have that and still not have prostate cancer, but that is usually one of the earliest signs that something may be going on with a man's prostate.
Wow. And I know we talked a little about having surgery plus radiation. So what are the treatments if a man has just been diagnosed with prostate cancer? What are his treatment options?
Okay, well, I guess the first treatment option, and anyone who's ever heard me talk know that I'm not a fan of this, is what they call active surveillance. Watchful waiting, they have different terms for it. I am not a fan of that for the reasons we just stated, especially African American men. If he's 2.5 times more likely to die of something, I'm not sure what you're actively waiting for it to do.
Right.
And the other thing is that actually some of the surgical series, when they look long term, especially at African American men who were put on active surveillance and maybe ended up having surgery, what they thought was an early stage, and I'm sure you've talked to men where they thought was an early stage prostate cancer, by the time they get to surgery, they're more likely that that tumor has gotten more aggressive and is more advanced stage than they initially thought it was. So for that reason, I am not a fan of active surveillance. I'm on record saying that. However, if a man and that's something else that really bothers me when I was doing some of my research, is that African American men, now here they are more likely to die of this, more likely to be diagnosed with this, but yet African American men are more likely to be told to do active surveillance, even though they're more likely to die, versus their white counterparts who, with the same presentation, will be told to get treatment. But
Why do you think? Why do you think that happens?
I have my own.
Well, yeah, you don't have to. I already know.
But that's why knowledge and education is important.
Right.
For anyone who's listening to this, just remember, if your doctor tells you active surveillance, just remember that. Okay, they've actually looked at men, head to head, with the exact same biopsies, exact same PSA, exact same staging, and the Caucasian counterpart will be told to get treatment. But the African American man will be told to do active surveillance. So,
right, and plus, if we're having a higher mortality rate,
yes,
then it seems like common sense would say, no, I need to deal with this while I still have a window of opportunity to deal with it.
Exactly, and that's an important point, because that window of opportunity is critical. Because if a man is diagnosed, okay, and anyone who's heard me talk will say that, and you can Google it, diagnosed and treated for prostate cancer, and we can talk about the different treatments, their 5-year survival rate is 99%. 99%, which is the highest treatment cure rate of any type of cancer that I treat. There's no cancer that I treat that has that higher cure rate, 99%.
Wow.
And that's 5 years, all right? 10-year survival is 95%. So it's still in the upper 90th percentile. So when a man is diagnosed and treated when the prostate cancer is still early and curable, basically we can cure him of the prostate cancer.
Yeah, 95% is pretty good. I mean, if the weather forecast says there's a 95% chance of rain, most likely it's going to rain.
It's going to rain, exactly. You can bet your exactly. You can bet all your money on that one. That's going to happen. You're right. So that's one thing. That's why, like you said, you have your ministry, and that's why I have mine, because it's like those numbers. I like the way you put that. We don't want to challenge those numbers. So those are incredible numbers.
Yeah. Wow. So how important is physical activity in terms of, or will physical activity prevent prostate cancer?
Well, that's a good question. And we don't have strict data. I mean, who actually does research on physical activity, right? But there are some indications that being physically active, especially, obviously for everyone, but especially for men, could decrease their incidence of prostate cancer, improve their survival from prostate cancer, even though they have very good survival, and lessen the chance of it coming back. That's one thing that I hear a lot from men. What if it comes back? So physical activity, changing their diet, having more fresh fruits and vegetables. I actually have a talk and a presentation that I give about that. That's one of the things that, depending on where you go, like Cleveland Clinic and places like that, will actually counsel you on changing your diet. Do, like I said, more fresh fruits and vegetables. Now, I'm not saying you have to completely convert over and become a vegan or vegetarian,
right?
But it's something to think about, what I call a plant-based diet. And anyone who's listening to this, they can actually Google that. So basically, it says more fruits and vegetables, as I just said, less red meat, more chicken and fish, lean cuts of meat if you must eat meat, but basically make more of your diet lean toward a plant-based diet, as I just mentioned.
Right. Yeah, so I have a question here somebody submitted. I think you may have covered it, but it says, is surgery a better option than radiation?
So I was actually going to go dive into surgery a little bit more.
Okay.
Surgery is an acceptable option. I have to put it that way. Only because I'm a radiation oncologist, I'm going to go into why I say it's acceptable. Surgery is an acceptable option for a man who has early stage prostate cancer, okay? That PSA is below 10. So there's a reason why I say that early stage. What does I mean by early stage? So let's say a man has had a biopsy and it's a Gleason's 6. Now that's important because that's kind of what we call a low-risk prostate cancer. For men with low-risk prostate cancer, surgery is totally an acceptable option. Why? Because when they go in there, if it's just Gleason 6, you heard me say just Gleason 6,
Right.
then they can take out the prostate, and as I've heard from some of my patients, they can have one and done, and that's all they need. There's two problems. The problem is that sometimes, unfortunately, especially for African American men, that's not all there is. When they go in there and do the surgery, they may find more disease in there than they expected. And if it's more bulky disease, if it's spread to the local regional areas, the seminal vesicles, and then a patient that I just recently had, if it's already spread outside the capsule, then they're going to need radiation afterwards. So then, we call it trimodality, but when I say tri, that means 3. What does that mean? Because after you have the surgery, you have to come to us for radiation, and now we have data that supports, then we have to put you on hormones during the radiation. So you need to either get one, to me, you get one treatment. Either get the surgery when you're low risk and only low risk. Those are the only people who should get surgery, all right?
Wow. So if your Gleason score is more than a 6, then you shouldn't even consider.
Exactly. Don't even consider it. And there's another caveat to that. And if you have more than 3 biopsy cores positive, do not consider it. Why? Because you're more likely to have more disease in there than they expected. Biopsy cores, they stick a needle in there, okay? It's kind of, I tell people it's like an orange. And you stick a needle in an orange, and you hope you get all of, like, let's say there's a bacteria in there. So you stick it in there and you get parts of it. So hopefully you think that's all of it, but obviously there could be some residual in there. But if you stick a needle in there and 8 of your biopsy cores are positive, that's telling you right there there's a lot of other disease in there. So under those circumstances, I do not recommend you have surgery. Plus the toxicity from surgery, no shade to my urology colleagues.
Right.
Those are the cases where the men get the incontinence, which means they can't handle their urine, okay? And for some of the men I've talked to, that's been, I won't say permanent, but it's been long-term. Right. There is a higher risk of erectile dysfunction. Your surgeon won't tell you that, but you heard me say 30 to 40% of men after surgery are going to be impotent. And that's if they have nerve sparing. If it's not nerve sparing, it's going to be 50 to maybe even 70 to whatever percentage. So they're really going to have a higher percentage. There's another part of surgery. I give talks to residents at the university that they don't tell you about, but unfortunately, if a man has surgery, he has a higher risk of having shortening of his penis. Okay? Wow. Which I don't think too many men want to sign up for that. They're not going to tell you that before the surgery.
I don't think so either.
Yeah, no. So all of those reasons, unless it's a very early stage, Gleason 6, 3 or less biopsy cores positive, yeah, I do not recommend the surgery. And unfortunately, there are probably men out there who are sitting there nodding their heads and wishing they had heard this information before they had the surgery. Yeah. That whole one and done, no, that's not going to be your reality, unfortunately.
Wow.
Now, radiation, which is what I do, not that we don't have side effects, but number one, we're not going to be shortening your penis because we're not, bothering any of that.
Right.
The radiation can cause some erectile dysfunction. It's not as high a percentage as it is for surgery. We tell people about 10 to 20%, okay? erectile dysfunction, you're not going to be incontinent. We don't affect your sphincter, so your urinary function will not be impacted at all.
Right.
But the other thing I mentioned, and anyone who's heard me talk knows that any man that I actually treat for prostate cancer, I start them on Cialis before I get started. And I do that for a reason, because radiation can cause, as I said, it can cause erectile dysfunction. So I start all men on Cialis. Because why? Because radiation can cause scarring and fibrosis. A man needs blood flow and he needs nerve supply in order to get an erection. Right. So I make sure that by giving him the Cialis, we keep those vessels open and keep that blood flow going, so he can continue to have erections even after the treatments are over.
Now, is that something a man could do even if he's getting surgery?
Excellent question. As a matter of fact, I'm on a podcast. Sorry.
Yeah. Oh, yeah.
Sorry, there. Hear me talking. Excellent question. There actually was a research done out of New York, and they showed that if a man actually started on Cialis before his surgery, he's less likely to have there's no guarantee, especially, they're still in there chomping and cutting.
Right.
That he has less of the erectile dysfunction. Apparently, it also seems to counteract the shortening of the penis. Okay.
Oh, wow.
Yes. So, but it's interesting, for whatever reason, your urologist won't think of that. As a matter of fact, I was talking to a urologist at a health fair a few months ago, and I mentioned that I start all men on that, and he was fascinated by that. And he says, "Oh, so maybe I should do that." And I'm just thinking, ooh, you have to say that to me? That it kind of scared me. So y'all never thought about that, huh? I go, yeah, I think you should. I think that would be a good idea. Yeah, before you take them to surgery. So, and I tell men that, the ones I'm fortunate enough to see before they go to surgery, that, yeah, your doctor probably won't mention that. Even another radiation oncologist, no one will mention that. Ask them for it. Right, they don't, the EMR, they can just click, and they can enter it and they can order it. So if anyone's listening to this, ask your doctor to prescribe it for you. They'll be happy to. Wow.
So listen, man, if you're listening to this podcast and you've already scheduled your surgery, talk to your doctor.
That's
right. You have to be your own advocate, your best advocate.
Right. Yes.
Wow.
So yeah, that's very important.
So how does this is a little change of subject, but how does medical mistrust impact early diagnosis in African American communities in terms of prostate cancer? Do you think?
Right. Go ahead. I'm sorry.
No. So do you think that plays a role?
Well, definitely. I mean, we know historically the healthcare system has failed African Americans in terms of diagnosis and treatment and follow-up treatment. So distrust of the healthcare system is real, and it's legitimate. It's nothing. It's not like it's your imagination. Unfortunately, for a lot of African Americans, if, as you said, they don't educate themselves or advocate for themselves, your physician or your primary care doctor may not even offer a PSA screening. Right. Why? Because of that study, what was that, about 7 years ago with the Preventive Health Services, that stated that men getting routine screenings for prostate cancer did not improve their survival, which really changed a lot of primary care doctors. The problem with that study and with that research paper that I actually told people, and I've actually been in meetings where this was discussed, I said, did you read that entire paper? And of course, whoever's giving the discussion hasn't read it. They've only read the first part of the summary. And I said, well, I read the entire paper. It was about 75 pages. I said, and what they say is that men who are at average risk of prostate cancer, but in the middle of the paper, okay, which is why there may be some bias or whatever things you may want to call that, they actually state that African American men, just by virtue of being African American men, are considered high risk. Wow. So actually, African American men should be screened for prostate cancer because they're considered high risk. So the data that African American men are more likely to be diagnosed and die from prostate cancer is known. I actually have graphs and charts that show that this has been tracked since the 1930s. So this isn't any new information that I'm giving people.
Right.
Okay, this has been known for a long time. So in a summary, so yes, the distrust is real. The distrust has a historic basis for it.
Right.
So that's why, as you said, education is so important and advocating for yourself is so important.
Yeah, because I know when I was diagnosed with prostate cancer in 2022, radiation and, well, they did give me an option, but it wasn't. But the conversation was more around active surveillance.
Mm-hmm.
That conversation was real strong, and the other two were very. It was mentioned, but it wasn't like they're trying to push me to do it. I felt like there was more. We don't want to do anything. We just want. So I asked a question. After I talked to you. So when I talked to you in 2022, I went back to the doctor and started sharing some things. I didn't say, just having knowledge now about some things.
Uh-huh.
And I said, well, what if I stay in active surveillance, what's going to happen? He said, well, basically, it'll keep growing, and then once it get to a certain place, I guess we'll try to do something. But to do something, then to me it may be too late to do something.
Yes, exactly. That's really, I like your thought processes about that whole situation, because as you said, what are you waiting to have? What are you waiting for? What are you waiting to have happen?
Right.
You're waiting to go from curable to incurable? I mean, what are you waiting for?
Well, that's pretty much what it is. I mean, it's nothing else in between.
Exactly. And I tell people that if you think about it, and I've said this to other groups, they don't tell women that. If they see something on a woman's mammogram, okay, they're going to say, let's go ahead and biopsy this to see what this is. They're not going to say, why don't you come back in 6 months and let's see if that's growing at all. Right. No, they're not going to do that.
Right. Yeah.
So they're going to advocate immediate action for that.
Right. So listen, man, if you have been diagnosed with prostate cancer, do something. Don't just wait 6 months and 12 months and 2 years. Mm-hmm. And once you lose that opportunity to deal with it, and now you have a major issue. So you have a big problem.
Exactly. See that window of opportunity. And I jumped ahead a little bit. I was talking about radiation. Okay, so this is what I do. So there's different types of radiation, as you already know. There's what we call photons, which is what we use, a traditional external beam. There is some people ask, how long does it take? It depends. There's a 6-week, it's a standard course. It's like standard course. Sometimes we can do a little shorter. Okay, we call SBRT, standard body radiation therapy, stereotactic body radiation therapy, which can be shorter. Some people have heard about CyberKnife, and sometimes that can be done in 5 treatments. And it's what we call hypofractionated, which means that we actually give large doses of radiation every time we give a treatment 2 to 3 times a week. Okay. And we can only do that, but it's important, as you said, that window of opportunity. You can only do that with very early stage prostate cancers, okay? We can't do that with the more advanced stages, because with the more advanced stages, there's a chance that tumor has spread to the lymph nodes. And so you can't do that hypofractionated treatment when it's spread to the lymph nodes, because there's too much normal tissue that would get that large dose. So you can only do that with small, isolated, localized prostate cancers. So then, of course, we have the proton therapy, which is kind of the newest and the best in terms of treatment. All radiation oncologists know about it. And what's nice about the protons is that it's high energy charged particles that actually go to the area of where the tumor is. It's very high tech, as you know. And it has what we call no exit dose, which means that it falls off in dose, so you don't get that dose to the rectum and all those normal tissues around it. So it's extremely conformal. And so that's why it's totally state-of-the-art. The toxicity is basically non-existent in terms of, because toxicity is the effect of radiation, when it's radiation on the normal tissue. We don't care about us damaging the cancer. We're just trying not to damage the normal tissue. So you get less damage to the normal tissues. That's why proton therapy is such a good option.
Wow. Now, what is the seed implant? What is that?
Exactly. So the seed implant is actual radioactivity. These are actually radioactive seeds that are implanted directly into the prostate, and that's what we call an interstitial implant. So under those circumstances, a man is taken usually to the operating room. All right. Sometimes he's put under general anesthesia or just local anesthesia. And the process is actual an implant, which means that there's actually guide wires where these radioactive seeds are actually placed into the prostate. Now they're permanent, okay?
Wow.
So they stay in the prostate. And what makes them effective is that, like I said, they're radioactive. So they actually give off their energy over a period of 3 to 6 months. And they're actually in there giving off their energy, but it's important for a man to realize that they are radioactive during this period.
Right.
So once a man gets these, he gets an implant like that, the prostate seeds, that he actually has to carry around a sheet of paper, because if you go anywhere that has anything to, a Geiger counter or something like that, some of the government offices to detect radioactive materials, you will trigger them.
Wow.
You go through the airport, you will trigger them. So yeah, that's something that a lot of people don't realize. But yeah, you're actually radioactive during that period,
Wow.
during that 3 to 6 month period. Yes.
Wow. So as we come to the close of the podcast tonight, what would you say to the man or men that's afraid to go get their PSA check? What would you say to those men tonight?
I would say, please think about, maybe not yourself, and I've said this before, but think about your wife, girlfriend, your mother, your sister, the people that love you and care about you, because we have an extremely effective treatment for prostate cancer. It is the most commonly diagnosed cancer in men. You didn't do anything wrong. You didn't eat too much pork when you were a child or when you were a teenager, or did something that you should not have done. It is just the fact that you're a man, unfortunately, increases your risk of having prostate cancer. And in African American men, remember, you had 2.5 times more likely to have it. Okay. So please just get screened, get information. Oh, that's something else. I was thinking about this the other day. And get a second opinion. All right. So whether you go see, like you said, your primary care doctor, you say watch waiting, yeah, right. Ask to see a urologist. Urologist said go to get surgery, yeah, right. Get another opinion. Ask the radiation doctor. Go and get all of those opinions, okay? Gather the information. Make sure you're well informed before you decide on any treatment. That's one thing I emphasize to everyone. Do not believe, no, I hate to say this, that one and done.
Right.
Because at least a certain percentage, at least 50% of the men that I treat were under the impression that all they would need is surgery. 50% of the men that I treat after surgery were under the impression they would not need anything after surgery, but then they did, because they were unfortunately at higher risk than they realized. Especially, like I said, the Gleason 7 and above, the chance of you having more local regional disease is very high. It's greater than 50%.
Wow.
Or PSA greater than 10. So then they're sent to me. So then they have to get the toxicity from the surgery. So now they're incontinent and they're probably impotent from the surgery. And then you got to come to me, and I just added to that. I don't add to the incontinence.
Right.
But me giving you the Cialis and Viagra after that is probably not going to help that much, because remember, you've already had this treatment. Right? So my medicine that I want to prescribe probably isn't going to help that much.
Right.
And remember, I told you it's trimodality now. So now you need to have the hormones. And unfortunately, once you have the hormones, the ADT, the androgen deprivation therapy, the medication doesn't really work, because it shuts off your hormone production.
Wow.
You see what I'm saying? You've gotten a lot of extra treatment, a lot of extra toxicity, when if you had really, really done, your due diligence, get all your information, hopefully you'll only need one treatment, and you can go ahead and continue to live your life and enjoy your life.
Right.
Okay. So everything I've told you is how you can live your life and enjoy your life.
Right. Right. Wow, some powerful stuff tonight. Just really appreciate you and all the information that you bring to the podcast each month. A plethora of great information.
Well, thank you.
And I'm really blessed. We're blessed because conversations with men, a lot of men listening at the podcast, and they found out that they had prostate cancer. So they are kind of, by listening to the podcast, they are ahead of in terms of getting information. So we really appreciate you just coming on each month. You're just still at work and you're coming on the podcast. So I really appreciate you.
Yes. Well, thank you for what you said earlier before we came on the air, that you said a man who was listening to the podcast, he didn't have any knowledge of prostate cancer or what to expect or what to ask for or anything like that. His doctor never screened him for prostate cancer. And then after he heard our podcast, decided to go get screened, and he was found to have prostate cancer.
Right. Yep. So even that right there, that alone is, it's for us to continue what we're doing in terms of getting this information out.
It is so critical. Like you said, this is your ministry and it is mine too. It is, like you said, the best, not the best way, but the one thing that you can say to me that will break my heart and make me actually flinch is to tell me that a man died of prostate cancer.
Wow.
Because
wow.
To me, with all the information I just shared, of all the cancers that I treat, and I treat them from A to Z, this is the only one that I can cure. So my goal is not another man die from prostate cancer.
Listen, man, no men should die from prostate cancer.
Right.
You heard it from the doctor. You're not just Matt Tillery, some guy, but you heard it from somebody who does this stuff every day. And she said no man should die from prostate cancer.
That's right.
So go get checked. Get your PSA. Your family needs you.
That's right.
So we appreciate you. Thank you again, Dr. Gooch, for coming on this month. I really appreciate you. Thank you so much for all that you're doing with getting the information out into every listener and those that's watching the podcast. I really appreciate you. Listen, go ahead and share this information, or share it with a man, even a woman, that they may be able to get the information to men. So just really appreciate all of you on tonight. Is there anything else you want to share tonight, Dr. Gooch?
No, you said it best. No man should die of prostate cancer. That's what should be the banner that we have across the front.
I'm going to get that made. I'm going to make sure we play that next month.
Exactly.
No man should die from prostate cancer.
Nope.
Wow, powerful stuff. Once again, I appreciate you, Dr. Gooch, for coming on tonight. Thank you so much for those of you that's listening on the podcast channels. I really appreciate all of the downloads. And to those of you that's watching over on Facebook, please share it. And if you're on YouTube, go ahead and subscribe to the ML Tillery Outreach. I would greatly appreciate that as well. Listen, I am Matt Tillery. Until next Monday night at 7 p.m., go and advance the kingdom.
We pray you have been empowered and blessed by this teaching. Join us next week for the Advancing the Kingdom podcast. If you would like to reach us, email us at mltillery@icloud.com.